Good morning. My name is Alexandra Lansky from Yale University, and it's my pleasure to be here this morning with Dr. Dave Morrow from Brigham and Women's Hospital in Boston. So we're going to be discussing your late-breaking trial, TRA, Secondary Prevention, TIMI 50, a novel antiplatelet agent for secondary prevention in patients with atherosclerotic disease. So, David, maybe you can give us a little bit of background on the study.
Sure, maybe briefly. The agent first, because it's an entirely new class of platelet blockers. It specifically blocks thrombins, activation of platelets by blocking the primary receptor for thrombin on the surface of platelets. And so this is the first study of this class of agents called the PAR1 antagonist in patients with stable atherosclerotic disease.
And tell us a little bit about the trial
Sure.
design. Is this a phase 2?
This is a phase 3,
okay.
26,449 subjects. The largest study that we've done. It was a broad group of patients. We enrolled patients with a previous myocardial infarction, previous stroke, or previous peripheral arterial disease. We had 67% qualified with myocardial infarction. That was a group of specific interest to us. And then the remainder, about 15% each, of PAD and stroke patients. They were all followed for about 2.5 years, staying on Vorapaxar or placebo throughout that entire duration on top of standard therapy.
So this is in addition to aspirin, so what's the standard therapy used?
It is. So in the MI group, just as an example, 98% were receiving aspirin, and then even just over 3/4 were also receiving clopidogrel, at least at the beginning of the study. In the PAD patients, it was about 1/3 that were receiving clopidogrel on top of aspirin, and then in the stroke patients, the background antiplatelet therapy, as is practice, was more heterogeneous, with just under 1/4 receiving a thiamapyridine.
So you've got a substantial portion of patients here on triple antiplatelet therapy.
Yes.
Okay, great. And so what are the endpoints? And give us the high-level key findings.
Sure. Our primary endpoint was cardiovascular death, myocardial infarction, and stroke, and it was lowered by 13% in the overall population, highly significant statistically result. We still think the most impactful finding is actually in the patients with myocardial infarction, where we saw a 20% reduction in that endpoint. Overall, the stroke patients who had been stopped early by our DSMB because of bleeding risk did not have any benefit from the PAR1 antagonist in this setting. In PAD, there was a pattern of benefit, but was not significant on its own.
So once again, speaks to the risk level of the patient.
It does.
And always seeing a greater risk reduction in high risk patients.
And I think also it takes away the concept that we've maybe had a little bit too popular over the past decade, that we should treat all atherosclerosis exactly the same way. And I think this study adds to evidence from stroke patients that that's not the case.
And tell me about the safety profile, the bleeding.
Yeah, so there was an increase in bleeding expected for a potent platelet blocker added on top, and so we saw overall an increase in gastro-moderate severe bleeding. That was our principal bleeding endpoint. And then in the intracranial hemorrhage was increased significantly overall, and particularly in the stroke patients. In the stroke patients, there was an absolute risk difference of 1.5% over 3 years. The rates of intracranial hemorrhage were much lower in absolute terms than those without a stroke history, which was the reason the DSMB made that recommendation to us. So it turns out to be about a 2 in 1,000 excess over 3 years in the non-stroke patients with this treatment.
Okay, and then I'm sure you've got a healthy PCI patient population in here with your STEMI and ACS patients.
So all patients had to complete their revascularization, so it was a little over 70% that had been revascularized. But really, actually, the outcome that had the most profound effect was actually spontaneous myocardial infarction, which really dominates the accrual of recurrent myocardial infarction in the stable population, and that's really in contrast to the trials that our group has led in ACS, where we see a very high proportion of PCI-related MIs.
Right. Well, the spontaneous MI is, of course, very important prognostically, so that's speaks
so
to the effectiveness.
It's good to prevent those.
Exactly. So what's the take-home message? What are the implications for the drug and patients and treatment in general?
I think two probably principal ones. I think scientifically, broadly abstracting from the medication that we studied, this is the first study that shows that there is a benefit to adding on to an aspirin-containing regimen for long-term secondary prevention. We've seen hints from other studies, but nothing conclusive until now. And specific to this agent, I think we see that if it were to become clinically available, it's investigational now, that you would have to select your patient appropriately, balancing the risk of bleeding versus the antithrombotic benefit. And we think our population, luckily, it's large enough that we've been able to identify groups of patients where we think that balance would be reasonable.
So who are those patients? Can you highlight that?
Yeah, so our patients certainly without a history of cerebrovascular disease. We found a significant interaction on body weight, so those are particularly low body weight, less than 60 kilograms, did not do well. And so I think those without a history of stroke, those with normal body weight, or at least not a very low body weight. I think age is probably something I would take into consideration for any potent antiplatelet blocker.
Great. Well, I want to thank you for taking the time to come and speak to us today. It's very exciting, and we're all waiting to hear the big fall presentation tomorrow. So thanks so much.